Disease relapse remains the major reason for treatment failure in patients allografted for acute myeloid leukemia. And although we've been very effective at reducing the toxicity of stem cell transplantation in these patients, we've really made very little progress in reducing the risk of relapse, and novel therapeutic strategies are urgently required. So our group has been at the forefront of developing the pioneering concept that delivering pharmacological agents after an allogeneic transplant may be an effective strategy to reduce relapse risk. The mechanism by which that may occur is unclear. With drugs like azacitidine, it may be that they epigenetically manipulate the alloimmune response, plausibly by increasing Treg reconstitution to reduce GVHD, or possibly augmenting the graft versus tumor effect by upregulating epigenetically silenced tumor antigens. Whatever the explanation, there is growing recognition that giving agents with inherent anti-tumor activity may manipulate the kinetics of disease relapse, giving the graft versus tumor effect longer to develop. In other words, buying time for the development of an effective graft versus leukemia effect. Our group and others have shown that subcutaneous azacitidine can be delivered effectively post-transplant, and we await really the development of formulations of this drug that can be delivered more easily in the post-allograft setting, and we're there now because a new formulation of azacitidine, CC486, represents oral preparation which is well tolerated, and interestingly the azacitidine pharmacokinetics are subtly different compared with subcutaneous azacitidine. So the data presented at this meeting are those of a phase 1/2 study looking at the tolerability of CC486 in patients allografted for acute myeloid leukemia. An MTD has been established at which the drug can be delivered with relative safety, and that means that we're now in a position where the next step really should be performing a randomized study to examine whether delivery of oral azacitidine at the MTD compared with patients who receive no maintenance improves survival in this high-risk population. So I think this is a real breakthrough, demonstrating that you can deliver azacitidine in an oral formulation, and it sets us up for an exciting possibility of exploring azacitidine as one of the agents that can be delivered post-transplant with the aim of improving outcome.